Ladies and gentlemen, I've been given the problem of talking about how to prevent a second stroke. We've heard already about risk stratification, and that, of course, applies to patients who've had a stroke and who haven't had a stroke. Before I continue, please take a moment to look at my potential conflicts of interest and note that I was involved with guidelines with atrial fibrillation. Let me start by saying that when faced as a cardiologist with a patient who has already had a stroke and who probably has atrial fibrillation, there are questions that we should ask. Firstly, we must ask about the first stroke. Was it a hemorrhagic stroke or an ischemic stroke? We have to know if the patient was anticoagulated at the time and what was the status of the anticoagulation. We have to ask about the patient. Do we know that atrial fibrillation is present and that it was probably responsible for the stroke? We have to ask about the thromboembolic risk and the bleeding risk. Now, I'd like to present two extremes of this situation. Firstly, a patient who was ischemic, who was not anticoagulated, who does have atrial fibrillation, who has a moderate to high thromboembolic risk and a bleeding risk that, let's say, is moderate. The second case I'd like to discuss is a patient who has a hemorrhagic stroke and was anticoagulated, has atrial fibrillation with a high thromboembolic risk and a very high bleeding risk. Now, first of all, our decisions are based to some extent on a detailed analysis of the results of potential anticoagulant therapies in patients with atrial fibrillation. And in order to look at that briefly, let's turn to the meta-analysis from Ruff and colleagues in the Lancet last year. This dealt with all 4 novel oral anticoagulants, and we see the results from individual trials. But notice that for stroke and systemic embolism, the primary endpoint of all of these trials, there was a 19% reduction. It was highly statistically significant. Notice also that in meta-analysis, there was a 14% reduction in major bleeding, and that this was nearly statistically significant. We know when looking at some of the subgroups of the endpoints in these trials that hemorrhagic stroke in particular and intracranial hemorrhage were very significantly reduced, but that ischemic stroke in general was not very highly reduced. If we turn specifically to the reduction of ischemic stroke, we can see that only in the RELY trial, with the higher dose of dabigatran, 150 milligrams twice daily, was there a clear reduction in ischemic stroke. And for this reason, many physicians would turn to using high-dose dabigatran in patients who have already suffered an ischemic stroke. But is that the right thinking? Should we instead look at trials in which there was a very high or large population of patients with a previous stroke? For example, in ROCKET-AF, 52% of the population had had a previous stroke. And we can see that the results of ROCKET-AF suggested that rivaroxaban was not inferior to warfarin in terms of stroke and systemic embolism when we look at patients who've had a previous stroke compared with those who have not had a previous stroke. Some, on the other hand, would say we should turn to a drug where the reduction in stroke in patients who've had a previous stroke is much higher than in patients who've not had a stroke. And that is reflected in the results of Aristotle, where we see for secondary stroke prevention that the hazard ratio in those who have had a previous stroke is 0.76, and for those without a previous stroke, 0.82. On this next slide, we are looking, however, at the other side of the coin, we have to look at major bleeding to see if that is also significantly reduced. And we see in Aristotle that the hazard ratios for the reduction of major bleeding were the same in stroke patients and those who'd not suffered a previous stroke. On this slide, I'm looking at all the hazard ratios from all the trials and doses of the approved drugs. And the lines in this table are those with previous stroke above and those without previous stroke below. And we see that those who have had a previous stroke, as far as the primary endpoint was concerned, there was no statistically significant result, although some of the reductions are clearly fairly substantial, but not significant because of relatively small numbers. If we look, however, at stroke, we can see that with apixaban, there was a significant reduction with stroke as a whole. But with ischemic stroke, none of the drugs or doses caused a reduction, although the point estimates were lower with in several of the trials. Hemorrhagic stroke, on the other hand, in patients with or without stroke, were generally reduced, and intracranial hemorrhage as well. So if we now try to compare these various drugs, not by a direct comparison, but using an indirect methodology where we try and adjust the results of the trial using the results in the warfarin limb of the trial in order to make the adjustments, we can then see that there is very little to choose between any of these agents. Importantly, there is no reduction within any of these comparisons, no dissimilarity whatsoever, and the only comparison which revealed any significant difference was a comparison of the low dose of dabigatran with largely the full dose of rivaroxaban. And if we look at that in more detail, we can see that it was hemorrhagic events that were reduced more with dabigatran 110, as one might expect, than with rivaroxaban. So what do the guidelines say about all of this? The American Heart Association and the American Stroke Association in 2012 published that for the prevention of first and recurrent strokes, we can choose any of these oral anticoagulants. But they made some differences by recommending warfarin at a class 1 level, dabigatran with a class 1 and apixaban with a class 1, but restricted rivaroxaban to a 2A. On the other hand, the level of evidence A was given only to warfarin. They made no really definitive statement as how to choose between these anticoagulants. The German guidelines, also published in 2012, said categorically that in patients with TIA or ischemic stroke, oral anticoagulation is recommended. They went on to say that patients with an ischemic stroke or TIA and atrial fibrillation should be treated with the new anticoagulants. They made some statements about apixaban being superior to aspirin as revealed in the Averroes trial. Now let's take that second patient that I mentioned who had a high thromboembolic risk but a very high bleeding risk and has had a previous stroke. Should we be considering the use of a drug at all, or should we perhaps think of a device-based therapy such as the insertion of a left atrial appendage occlusion device? Here we see the results of the PROTECT-AF trial, and this refers to patients who could take warfarin as well, and it refers to patients in general rather than specifically patients who have had a previous stroke. But we can see pretty impressive results with a 40% risk reduction in the primary endpoint of stroke, systemic embolism, or cardiovascular or unexplained death, a 34% reduction in all-cause mortality, a 60% reduction in cardiovascular mortality, and an 85% reduction in hemorrhagic stroke. Because of this trial and several other registries and one other randomized trial, we're now encouraged to think about the use of a left atrial appendage occlusion device in patients who have ischemic stroke despite adequate anticoagulation or who have very high thromboembolic risk but previous intracerebral bleeds on anticoagulants. There are other potential indications, but they seem much less pressing. Thank you very much, Mr. Chairman.